Again, Again, because primary pediatricians or the physicians who see children are probably not aware because they've never been told about childhood cancer. They've never been taught about childhood cancer during their training. Even in the same country, there would be the same country and the same training. For example, if you're doing your post graduation in pediatrics, there may be centers which would have access, which would have children with cancers, and their trainees would have access to that. They would have seen them during their training, but in many countries they would not have such an access. So many centers, they were smaller centers, would not. So the entire postgraduate training finishes without a diagnosis, without having seen a single child. Even when you suspect a child, there are poor access pathways to healthcare. So whenever you are not, there is no formal referral system in many countries, and by the time the child reaches a tertiary care center, often it is too advanced. Disease characteristics, definitely, like many of the patients that we see at least have high disease burden by the time they come to us, or they're already treated on some by quacks or by some indigenous medicine, which is half-hearted effort. So many a times they become drug resistant by the time they reach us. Classical example is acute lymphoblastic leukemia. They are given steroids previously, and they become prednisolone poor responders by the time they reach. Another host characteristic which is important, again, another big barrier to childhood cancer care is malnutrition. And again, so food is to be considered as important as that of a medicine like a chemotherapeutic medicine. And we have to incorporate ways to give them good food and continue to give them good food during this treatment. And that's where nutrition related civil societies become very important in the care of these children. A lot of children come with multi-drug resistant infections on board, so that significantly increases toxicity of these children. A lot of patients, when they hear the word, patients or parents, when they hear the word cancer, there is a big stigma, there is a fear of chemotherapy, and they run away when they hear a diagnosis. So that social support team is extremely important in delivering the care. There are a lot of treatment-related issues in these children as well, from infections to blood donor scarcity, to a lot of viral infections in maintenance, and so on and so forth. And finally, drug quality as well. So when we think of childhood cancer, it's not a single problem in its entity. There are a whole lot of issues that encompass this. And unless we address each one of them, our outcomes remain suboptimal. And this is where bringing in pediatricians to this whole gamut will improve, because they are the primary contact points, and they can help us in many which ways. They can help us refer early. They can help us not treat them partially earlier. They can help us by not giving additional antibiotics early enough, so by reducing antimicrobial resistance. They can counsel families at diagnosis as well as at relapse, so that their adherence to treatment becomes better, and overall shared care as well as long-term outcomes become good. So in global versus Asia, this is again standard statistics that in high-income countries, more than 80% children survive, whereas in Asia as well as many LMICs, the survival is to the tune of 20 to 30%, barring certain tertiary care centers which would have better outcome. So again, these are the same causes that I listed, and this is one of the profound inequities in child health. So from a child health perspective, from the IPA perspective also, this is one of those conditions where childhood cancer is one of those conditions where the inequities in healthcare are very glaring. So the median delay to a healthcare facility is 2 to 6 months, and there are multiple consultations before referral, from a surgeon to a pediatrician to a lot of doctors would have seen the child, and there would have been multiple rounds of multiple diagnoses. For example, sometimes it could be even diagnosis like rheumatoid arthritis or diagnosis like lupus, etc., which would come in even before childhood cancer is thought of. So these are the warning signs brought out by different organizations. IOP has its own set of warning signs. So any child, so this is the message that should go out into the community, that a child presenting with any of these warning signs should be thought of as cancer and should be referred early. And this is how we are going to address the barriers in LMICs in the upcoming session, that how to improve medical training, how to improve access to good diagnostics, how to reduce workforce shortage, how to reduce essential medicine stockouts, and how to improve the referral systems. So I'll stop here, and I'll hand over back to you, to the IPA team, for introducing the next speaker.
Thank you very much, Dr. Nita, for that excellent presentation. We're going to have another presentation from Dr. Ritu Bala. And before we hear her, she's actually a two-time blood cancer survivor from New Delhi and a leading survivor advocate with Kids Can Connect, the teenage and young adult survivor network of Can Kids Can. She is a strong proponent of patient rights, stigma reduction, and survivor well-being. She delivered the opening statement at the WHO CRO Regional Meeting 2019 and was invited by ICMR 2025 to articulate patient expectations from research. Her contributions include leadership in studies on gender bias in childhood cancer, tobacco awareness among survivors, and post-treatment quality of life. She serves on the Governance Council of the Indian Childhood Cancer Initiative, ICCI, and the Survivor Network Development Working Group of CCI Asia, and is recognized with her survivor spouse as a survivor power couple. Wow. It is really a privilege for us to be listening to Ritu today. So over to you, Ritu.
Thank you so much. Thank you so much for having me and inviting me to this multi-stakeholder advocacy, Cancer Awareness Week. And congratulations to all of us because we are doing it for the good, and it is necessary indeed because I myself has faced a lot of, um, the bad stuff as a cancer patient, and then later as a cancer survivor as well. So I quickly introduce myself. I'm two-time blood cancer survivor. I had ALL and NHL when I was 4 and then back at the age of 11. I was when I just think back out of my story and connecting it with the topic which we are talking really about, highlighting the advocacy point to the pediatrician across the world and global level. Um this had happened to me also, while my parents did not figured out why I was having fever for flat 3 months when I was 4 year old. They went to the local pediatrician back and forth again and again, but he could not, recognize because he didn't have that kind of knowledge that it could be a bigger, illness. And in the last, they had to, because I was not getting well, and they had to, take me to the nearby bigger hospital where I was admitted for 1 year, and doctor were kept treating me. They had given me chemotherapies, but after 1 year there was no improvement, and they have lost hope that and they have told my parents that we don't think she will be able to survive. You might need to take her home. And my father and mother, and I came from very humble background. We're very suffering with the finances, with the kind of emotional support from the family and friends, that back then it was really difficult for my family to handle that situation. And then they found another way. They went to some alternative. They found an alternative medicine, local medicine center. And a very this is very important fact. When you abandon the treatment in between and you went to some other homeopathic or alternative medicine without consulting your treating doctor, it may cause your relapse. And it had happened to me. I got cured in just next 3 months and then relapsed with NHL again with at the age of 11. I had a very long, 3 knots in my left ear, and I was in fifth class. It was difficult for me to study, to cope up with my day-to-day lifestyle. I was really a bright kid, competitive, super energetic, proactive, but I was certainly, not able to do anything. And then my treating doctor who was there at the age of 4, he suggested, take her to AIMS, All India Institute of Medical Sciences in New Delhi. There I got treated for 2 years, and there were a lot of struggles because my parents never, been to such big hospitals. So for first 6 months in All India Institute of Medical Sciences, because there was no awareness, and there was no guidance, nobody to help and held my parents' hand. We went to some different department, to hematology department, and that was not for me, for not for like kids. I got treated 6 months, and my knots got really bigger, and it was painful. It was really, hectic, and very difficult for me to cope up as a child. And then after 7 months, we found out that this is not the correct department. We went to IRCH, and then occasionally uh, I meeting different people in different NGOs. They help us to navigate through the different. So this was just not a struggle and barriers on the ground level which I face as a patient during that time with my family, but there were a lot of different factors. Finances, there was nobody to support at that time. There was no awareness about such NGOs or self-help group who can support. There was no like information there in the hospital premises where we can approach hospital for the grants. And then also when it backs to the social factor, it was also hitting us. There was nobody coming and helping us with the education, with the normal psychological aspects. There was no support in terms of the family. My siblings got really in trouble, and it was really hectic and difficult for me to cope up. And then later when I got cured, I just take a pledge that whatever I faced, I will never let other children do the same. So therefore, in my childhood only, I started volunteering for this cause and joined Can Kids Kids Can as a volunteer. And then later in 2006, we started Kids Can Connect, and to support and help survivors to reintegrate back into the society as a normal person. As a survivor also, right till now, I had to face a very much difficulty on socio-economical, on every aspect. People don't give us jobs because we are survivor. They think that we can cause cancer. This is a wrong notion in the society. There are wrong, there is a stigma attached to it. People don't give opportunities. People don't give education. They don't give children admission back into the school because they think like they spread infection to other kids. This is a certainly wrong notion, and we have started working on it since 2006. And my group, which is like right now 5,000 plus survivors, it's the largest survivor group in India. They are now working pan India to just to cut short these wrong thought processes. And right now, talking about me as a professional career woman, I because I have taken pledge, I make sure that I spare my time in the weekends, and I work for volunteering for the projects which can definitely bring change in the childhood cancer on the policy level, on advocacy level. And I represent my survivorship from India to different organization who have different stakeholders, governments, social support teams, corporates, who can bringing a lot of ability to make those decisions. So I bring a lot of uh, problem statements from the ground area and help them to resolve it.
Thank you very much, Ritu, for that heartfelt talk. We really are grateful. I'm sure people will now appreciate why I introduced her as Dr. Ritu. You see, many
I'm
of
not
us
a
when
doctor. I'm a
I
cancer
know,
survivor.
I know. Many of us had to sit in the classroom to end ours. You lived it. So your learning is actually not just what people told you, but what you experienced yourself. Thank you very much for being able to share
Thank
the story of your life and working to make a difference in that field. We appreciate you. Thank you very much. Now we're going to have our next speaker, and this is no other person than Professor Regine Kebudi. She is the Secretary General-elect of CEOP and Professor of Pediatrics and Pediatric Hematology Oncology at Istanbul University, Sarah Passan, an internationally recognized leader in pediatric solid tumors, neuro-oncology, and adolescent young adult oncology. She has significantly influenced global supportive care standards through her leadership as chair of the CEOP Supportive Care Working Group. Her extensive contributions to clinical research, guideline development, and international collaboration platforms continue to shape policies aimed at improving survival and quality of life for children with cancer. So over to you, Professor Regine, for your presentation.
Thank you very much for the introduction, Dr. Ekanem. I'm very happy to be here. And I would like also to welcome our participants online and the moderators. And I would like to thank Dr. Nita and Dr. Ekanem especially for organizing this very important session, which is a joint session of the International Pediatric Association, IPA, and the International Society of Pediatric Oncology, SIOP, during the London Global Cancer Week. I am a professor of pediatric hematology oncology, general secretary of SIOP, and have served in the Istanbul University for over 35 years. And we work in collaboration with a lot of partners and especially IPA. And as you know, in November 20, it was the World Children's Day, where we all wanted to say that every child everywhere has a right for a healthy future. And now for this seminar, which is No Child Should Left Behind, Role of Pediatricians in Childhood Cancer, we want to emphasize that every child everywhere, every child with cancer everywhere needs a prompt diagnosis, prompt diagnosis, appropriate diagnosis, and appropriate treatment wherever they are in the world. I have no conflicts of interest. And as Dr. Nita has already told you, this is a map provided by the WHO, the World Health Organization. And you can see that in North America, Western Europe, there's a very high survival rate. More than 80% of children can be cured, the children with cancer. However, this is not the same in Africa or in parts of some parts of Asia or some parts of Latin America. So to solve these inequities, the WHO, the World Health Organization, has initiated the Global Initiative for Childhood Cancer in 2018. This aims to achieve a survival rate of over 60% in low-middle income countries by 2030 in the 6 cancer types which are highly curable in high-income countries. And these are the acute lymphoblastic leukemia, Burkitt lymphoma, Hodgkin lymphoma, retinoblastoma, which is an eye tumor that is seen only in young children, Wilms tumor, and low-grade gliomas. Of course, we want to cure all children with cancer, but at least the ones that are highly curable, and this can be achieved by 2030. And we, as many partners, SIOP also is a non-state actor in official relations with the WHO. IPA also is a partner of the World Health Organization and other partners like Century Global. We are all aiming to achieve these goals. How can we do that? We can do that only by improving early diagnosis, where pediatricians and primary healthcare physicians are very important, and by giving a quality of care through global collaboration. And that is the aim of this session as well. Early diagnosis, but also we want to have the global collaboration of all societies, all partners. Education is very important, especially the cancer in children are different from cancer in adults. And in children, we do not have the screening test like for mammography for breast cancer. No, we do not have that. So what we rely on is the signs and symptoms of pediatric cancer. So we have to educate on the signs and symptoms of pediatric cancer for early diagnosis. And we have to increase the awareness, both in the healthcare professionals, both and in the community. And when we say education, this education is in the primary healthcare professionals, physicians, nurses, and also pediatricians, because as has been said by Nita, by Dr. Ekanem, Dr. Nita, first the child would go either to a primary healthcare professional or the pediatrician. So they have to know the signs so that they can make the diagnosis and then send them to the appropriate center for treatment. We also have to educate the community. The parents, teachers, and the social media, the TV programs are very important to educate the community as well. And the foundations are very important. We just heard Rita, and that was really a very, very good talk. Thank you so much for being with us, because the lived experience of survivors is very, very important. They have lived it through. They have lived all the challenges that there was. And we are here as the professionals, healthcare professionals, and also the survivors, families, patient advocates, to solve the challenges, to overcome the challenges for a brighter future for these children. And also we have to educate the pediatricians and primary healthcare physicians, not only for the early diagnosis, but also for the supportive care and palliative care of these children. Because during the treatment, we have, especially when a child comes with fever and neutropenia, and they can come to a pediatrician that's closer to them than their center, that pediatrician has to be very prompt in treating them with prompt antibiotics. In the golden hour, even in the first hour, they have to be treated. So this is very important, both the early diagnosis and also the supportive care, where pediatricians are also really vital in improving the outcomes of children with cancer. How can we do that? I will be giving examples.
Sorry to interrupt you, Professor Regin. Please, can you put your on slideshow? Is that possible?
Yeah, I tried to do it, but I could not. So that's why I just went.
If it's not working, you can go on.
It didn't work. You. Yeah, that would have been better, but it's not. The function is not working. But can you see my slides? At least, even though they are not in the highest mode.
We can see them.
Yeah,
please go ahead.
Okay. So I will be giving examples of what we are doing in Turkey, and also in my home country, and also in the world. What we're doing in Turkey, we have the Turkish Pediatric Oncology Group. And here I have to say that the national pediatrics associations, the societies, and the national pediatric hematology oncology societies are really very instrumental in giving this education, because almost in every country, there's either annual or biannual meetings of the pediatric societies and the pediatric hematology oncology societies, and we have to collaborate with them. That's what we are doing in Turkey also. And so both the Turkish Pediatrics Associations and the Turkish Pediatric Oncology Group, and also the Turkish Pediatric Hematology Group, we have two societies and we collaborate with each other, the Turkish Pediatric Oncology Group and the Turkish Pediatric Hematology Society. In our meetings, especially in the pediatrics meetings, we have some sessions, short sessions on the early diagnosis for pediatric cancer that we deliver to pediatricians. We have done that in international meetings as well, like the Europediatrics. This was that was done in Antalya, but that was done in the one that was done in Dublin. I personally have given some lectures, and many other colleagues, on the early signs of pediatric cancer. And also in the Cancer Week, we have done, especially in the COVID time, we learned how to do everything online. We did an online educational session on the early diagnosis of both pediatric cancer and adult cancer. And we had 5,000 participants from all over Turkey and Turkish-speaking countries. So I think the online courses and also in-person courses, the collaboration between pediatric associations, pediatric hematology, pediatric oncology associations in each country is very important. And of course, it is very important in the international level, like the International Pediatric Association, IPA, is doing, like SIOP is doing. And SIOP and IPA also collaborated in one other important educational activity, and that was the CEDAR project, the Childhood Cancer Early Diagnosis and Appropriate Referral, an educational initiative of the SIOP and IPA together. And there we had sessions on this 6 index cancer that have been identified by the World Health Organization for the Global Initiative for Pediatric Cancer. And these were very well attended. So we have to reach the primary care physicians, the nurses, the pediatricians with these educational activities, either in person or online. And there are other projects also for disease-specific learning, but here we want the early diagnosis, especially, to be done correctly. To do that, also when we are educating, we have to know that the pediatric cancers are different from adult cancers, and what we see most is leukemia, brain tumors, and lymphomas make up more than 50% of the pediatric cancers, followed by neuroblastoma, soft tissue sarcomas, Wilms tumor, bone tumors, retinoblastoma, and others. And but the age is important. Like in infants, it's not leukemia, but neuroblastoma that's the most frequent. And in adolescents, it's more lymphomas that are more frequent. And in adolescents, you can see thyroid cancer or skin cancer, which which is quite the thyroid cancer and skin cancer is rare in younger children. As Dr. Anita has said, there are a lot of warning signs by different societies. All have the same aim, to have some clues for warning signs that you can remember. One of these is the children. You have the first letters of children in each line, like continued unexplained weight loss, headaches with vomiting in the morning for brain tumors, increased swelling, persistent pain in bones and joints, which can be seen in many cancers, a lump or mass wherever in the body, development of the white tissue appearance in pupil, the brightness in the pupil, retinoblastoma. This is rare, but when it can be diagnosed early, you can save the life and the vision of the child. Recurrent fevers that caused by infections, excessive bruising, bleeding, noticeable paleness or prolonged tiredness. These are some of the warning signs. Leukemias are the most frequent, and we have to know that in children, it is acute leukemias, 95%, not chronic as many adults do have. And because of the bone marrow infiltration, the child can present with anemia, leukopenia, leukocytosis, thrombocytopenia, where they have paleness, tiredness, fever, bleeding, or enlargement of the liver and the spleen, enlargement of the lymph nodes, mediastinal mass in some of them, and other symptoms. In the brain tumors, we have to know that headache, vomiting, lethargia, that is falling asleep, is one of the general signs for increased pressure of the brain, but there can be disturbances of gait and balance, that's ataxia, cranial nerve abnormalities, impaired vision, mental disturbances, seizures, motor dysfunctions. And I have to say, as I said, the social media is important, and also TV sessions on health for pediatric cancer. I can always remember that one of the teachers saw that the child was trembling, the hand was trembling when she was writing, and she told that to the parents, and she apparently was having hemiparesis, a very mild one, and was afterwards diagnosed with a brain tumor. So it's very important that, of course, we teach pediatricians, we teach healthcare professions, but it's also very important, the social media nowadays and the TV health programs are very important in disseminating knowledge. And the brain tumor symptoms can be different according to the location in the brain, like some can have seizures, hemiparesis. If it is infratentorial, you have the ataxia, clumsiness, dysmetria, or cranial nerve palsies most of the time. And if it is in the middle of the brain, then you can have some hormonal dysfunctions like the early puberty, puberta precox, or the diabetes insipidus, upward gaze deficiency, or the diencephalic syndrome. And these children are usually seen by many people that are, whether they are malnourished, but it is the hypothalamic tumors can cause failure to thrive, emaciation, losing weight, euphoria. They look euphoric as well. Low-grade tumors of the brain is one of the GICC index cancers because they can have a survival of over 90% after 10 years. So it is good that we really recognize the symptoms of the brain tumors. Lymphomas, Hodgkin or non-Hodgkin. Hodgkin lymphomas usually present with asymptomatic cervical lymph node enlargements. As you can see, it's painless, rubber-like, and there's an indolent slow growth. And 2/3 of the patients can have a mediastinal lymphadenopathy, and they can come with cough, respiratory symptoms, dyspnea, orthopnea. So in children that are coughing, but more than 10 days, 15 days, just try to make a chest X-ray, not CT, and see if there's an enlargement of the lymph nodes, if you have ruled out infection, of course. And B symptoms, fever, drenching night sweats, loss of body weight is important for Hodgkin's lymphoma if they have a B stage. Lymphadenopathy is seen in children a lot of times, and it is mostly because of infections, of upper respiratory tract infections, but we shall not forget that lymphomas, Hodgkin or non-Hodgkin's, or sometimes ALL, leukemias, or nasopharynx carcinoma or nasopharynx rhabdomyosarcoma can present with NIC lymphadenopathies. Non-Hodgkin lymphomas, pediatricians have to recognize this very important. This is important because they have the highest doubling time. They grow in 16, 18 hours, they grow twice. So we have to be very quick. And if we are suspecting non-Hodgkin lymphomas, the pediatrician has to, even without making the diagnosis, has to be very quick in making the diagnosis and having adequate hydration, because of the tumor lysis syndrome, they can have renal failure. And sometimes in the past, many people are still in some low middle income countries, they can die even before the diagnosis because of the tumor lysis syndrome. The Burkitt lymphomas, which is one of the index cancers, can present in the abdomen or in the chin, but it can be in the mediastinum and other parts of the body. In the intra-abdominal masses, if it is a young child, neuroblastoma and Wills tumor should be in the first differential diagnosis, and lymphomas in older children, but there are others that can be in the abdomen as well. Wills tumor is also another one of the GICC index cancers because it has a very good survival rate, and usually they will present with abdominal swelling, hematuria, hypertension. And ultrasound is the easiest way to first look whether there is a mass in the abdomen, whether it is in the kidney or other. And neuroblastomas, which are the most frequent in infants and also in young children, they can come also with the same abdominal pain, abdominal swelling, can have hypertension as well. And because they have an affinity to spread to the bone and bone marrow, they can come with bone pain and sometimes with some anemia or thrombocytopenia as well. Soft tissue sarcomas can be seen everywhere that there is a soft tissue in the body, but 40% would be in the head and neck, and the orbital ones do very good. And genitourinary tract, like in the paratesticular in boys, which also do quite well, or uterus or vagina in girls. It can be in the extremities and any other part of the body. Also, bone tumors, especially if there's bone pain at a special site, swell, which then afterwards can be swelling because if from the bone it has gone to the soft tissue, immobility, pathologic fractures. Think of the bone tumors. Osteosarcoma and Ewing sarcoma is the most frequent bone tumors that we see in children. And do not forget retinoblastoma. Every pediatrician and every healthcare professional, when a child comes, should look also to the eyes. When you shine a light in the child's eye, the pupil looks red because of the blood in vessels in the back of the eye. In an eye with retinoblastoma, the pupil often looks white or pink. This white layer of the eye may be noticed after a flash picture is taken. And the retinoblastoma patients usually come with a brightness in the pupil, and it cannot be seen everywhere, every time. And if you, the pediatrician or the healthcare professional, did not see it, but the mother says, I see sometimes brightness in the pupil, please look at those children and send them to an ophthalmologist, because it is with the fundus examination that the diagnosis is made. They can come with strabismus or, as I said, leukocoria, brightness in the pupil, which we also call cat's eye. It's seen in babies and young children, and if it is in both eyes, it's always hereditary. But if they can come early, you save the life and the vision. If they come with spreading in the extraocular part, as you can see, there is quite challenges in the treatment. And cancer registries are very important, and this national cancer registries is the most important, but the hospital-based registries is also important in many countries where some centers are the referral centers for pediatric cancer. And we have to know the cancer register is important because cancer should be a mandatory notifiable disease, first of all. And register is important so that the country knows how many children with cancer they have, and so that they can manage for their treatment and they can put it in their national cancer policy. So all pediatric cancer care should be in the national cancer policy. And in fact, another thing is that is very important, there should be universal health coverage. Families should not pay out of pocket to make the diagnosis or the treatment for the children with cancer. It is a very expensive disease, and it is already time consuming and needs a lot of energy. But in many of these low middle income countries, the economy is not good of the families. So there should be universal health coverage. And I will be telling about it, that we are trying to do that and advocating for it in the highest level in the United Nations. As I say, national pediatric associations and national pediatric oncology and pediatric hematology societies are very important. And in Turkey, we have a pediatric cancer registry by the Turkish Pediatric Oncology Group, and also one by the National Ministry of Health. With the Ministry of Health, we know the incidence. With the one that the Turkish Pediatric Oncology Group is doing, and also it is done under Professor Kutluk's guidance. We also know the survival as well. As I say, and we have seen that the frequency of cancers is the same in both groups. And also hospital-based information is very important. In the Istanbul University, before even we had the Turkish Pediatric Cancer Registry, retrospectively, we went over all our cases for 22 years. And we have seen that in 2002, we had the health reform, and there was universal health coverage. What we did before and what we did after. Of course, during the time, the education has changed. The pediatric national oncology and hematology societies did a lot of educational activities to their members, pediatric associations as well, but especially universal health coverage was very instrumental. And we have seen that many children could be diagnosed earlier than before, and this was significant. And many of these have consequently affected the survival, the increase in survival. So early diagnosis was very important, and also supportive care was very important, because in children with cancer, we give a lot of intensive treatments, and they have neutropenic, they need transfusions. If you can do good supportive care, you can give the intensive treatment. Otherwise, they will die because of the complications of the treatment. So it is very important to have early diagnosis, multidisciplinary approach, teamwork, and experienced centers. And we need pediatricians. We need pediatricians in the early diagnosis and also in the supportive care as well. And in our experience in Istanbul University, of course, for the children, we do a lot of multidisciplinary teamwork, tumor boards, and for the supportive care, because we saw that in the 1980s, beginning of 1990s, we had a lot of complications because of febrile neutropenia and also mortality. We made a working group for pediatric febrile neutropenia. This was not only for pediatric hematology oncology, this was also for pediatric infectious disease specialists and pediatricians. We went to many public hospitals to teach pediatricians that when a child with febrile neutropenia would come, they have to be treated promptly with broad spectrum antibiotics. Otherwise, they would die in a few hours, even if they can go into septic shock also. This was really very important in the importance in increasing survival and decreasing complications. The duration from symptoms until diagnosis, in our study also, we have shown that this has decreased, especially for retinoblastoma patients. And there has been a very new publication from Peru, very recently in Pediatric Blood and Cancer, where they have seen that with the implementation of the Global Initiative for Childhood Cancer by the WHO in Peru, they had the median diagnostic time, symptom diagnosis has decreased, and especially it has decreased in the median first contact to diagnosis, first contact to the healthcare facility and diagnosis. And we will see that in the future, if this will also, I'm sure it will, change the survival, will lead to increase in survival as well. And so in our study, in our 22-year retrospective study, we have seen that the CICC cancers, lymphomas, and retinoblastoma, renal tumors, they have a survival rate of over 90%, like in Hodgkin's, 98%, in low-grade gliomas, 95%, in leukemias, 82%, because there are also a lot of high-risk leukemias. Otherwise, in low-risk leukemias, it is over 90%, close to 100%. So as I said, the collaboration is very important. The IPA and SIOP collaboration in CEDAR project was quite successful. This has been published, and you can see that all the in-person participation, live participation was up to 430 people, but afterwards this can be seen in the SIOP YouTube channels. These are early diagnoses for these 6 index cancers. Like for leukemia, there were more than 1,000, and for Burkitt lymphoma, almost 2,000 views of the seminars. These are very important. Global mapping is very important. This is a project of SIOP. We aim to locate and share a map with every center and facility for pediatric cancer in the world. And this has been completed for the Latin America and Africa, and the other continents is ongoing and close to completion. And thanks for everyone that has helped in this project, and also the leadership of our Professor Shantada and all our other members that took part in this global mapping, Maite, Neil, and all. And because Neil also is in the global cancer week in the management, and so we help everyone that has taken part in that. And there's an area guide. This is more for pediatric hematologists, oncologists, but this is a project of SIOP and St. Jude Global, but it has parts for the diagnosis, and also it is done in such a way that there are roadmaps for high-income countries, or depending on your resource, where you are in a resource-limited country or a resource-rich country, where you can guide the diagnosis and the treatment. And also, it is very important that we take these to the high level. As I said, universal health coverage is very important. Having pediatric cancer in the national cancer policies of every nation is very important. We have that in Turkey, and we are lucky we have universal health coverage, and we have seen how this can improve the survival in pediatric cancer and also other fields in pediatrics as well. So in the United Nations, United Nations General Assembly in 2023, there was a session organized by the World Health Organization and St. Jude Global, and we were invited. And there also we talked about the importance of universal health coverage and having pediatric cancer in the global, in the national cancer policies of each country. And also this year, in 2025 September, there was also the United Nations General Assembly, and we have worked so much for it. In SIOP, we have the WHO committee that is really working very hard, and we were able to have it in the draft of the high-level declaration. It is not signed yet, but at least it could be put in the draft, the childhood cancer, that we have it, that it is very important to have it in the national cancer policies and universal health coverage. And so we had both in the United Nations headquarters, the meetings, and also Memorial Sloan Kettering was very kind to invite us for a joint session with SIOP on advancing the global initiative. Because in the global childhood cancer global initiative of the WHO, the pediatric oncology, pediatric hematology associations are very important, like SIOP and all others. And IPA is very important. All pediatricians are important, because first we have to make the diagnosis, and then we can treat the patient. We can do only with collaboration. The collaboration in our center, multidisciplinary collaboration in each of our centers, multi-center, national, regional, and global collaboration. Like today, we are doing it with IPA and SIOP. And also, it's very important to include the survivors, families, and patient advocates, like the Childhood Cancer International. And Rita was a very good example and she's working for this aim. And we thank all of those people as well. And so to achieve the GICC goals, early diagnosis and you pediatricians are very important. International collaboration is very important. Universal health coverage is very important. With this, I would like to thank you I would like to thank the organizers and also all the participants for their attention. And I would like to announce that SIOP 2026 will be in Texas and the next IPA is in Rwanda, right, Dr. Ekanem and Dr. Nita? And also SIOP 2028 will be in Istanbul. And we want you all pediatric hematologists, oncologists, pediatricians, and we look for further collaboration. Thank you so much.
Thank you very much, Professor Echin. You're absolutely correct. Rwanda is loading 2027. So we appreciate that excellent presentation in the last few minutes. She has taken us through innovations in early detection programs, advances in screening strategies, early warning tools, talked about successful pilots, experiences from Turkey she has shared, and talked about the role of universal health coverage. Once again, thank you very much. Now we're moving, and our next speaker is in the person of Dr. Jevrog Tamamian, who is a professor and chairman of the Department of Hematology and Pediatric Oncology at Yerevan State Medical University and head of the Pediatric Cancer and Blood Disorder Center of Armenia. As the SIOP Continental President for Asia, he has been instrumental in advancing childhood cancer control through regional capacity building, multidisciplinary cooperation, and policy engagement. His scholarly work focuses on early diagnosis, collaborative system strengthening, and improving equity in access to high-quality pediatric oncology services across Eurasia. So it is my pleasure to welcome Dr. Jevrog. Over to you now.
Hello, everyone. My name is Rosanna, and I'm Chief of Pediatric Oncology Department. And today I will be presenting on behalf of Professor Gevorg Tamamian, and who unfortunately could not join this meeting due to unforeseen circumstances, and he sent his sincere apologies for that. It's my great honor now to share his slides and key messages with you all. Thank you. So let me begin with a simple photo. You see what you can see here. It's two cities, two skylines, two places that looks almost identical. Same buildings, same streets, same noise, same hectic daily life. If I ask you what makes them different at first glance, the answer would be probably nothing. But reality tells a different story, because behind these visually similar cities lies one of the greatest inequalities of our time, one that does not appear in our parliament, in our headlines, but appears brutally in the lives of the children. On the next slide, what you can see, you see a mother holding her child's hand. Now imagine this. If this child lives in a city 1, the chances of surviving the cancer, and it's no matter which type of cancer we are talking about, it can be the exact same leukemia or lymphoma or any other tumor, the chances of surviving the cancer is 400 up to 500% higher than if the same child lives in a city 2. Same disease, we're talking about same age, same biology, same photo, but utterly different destinies. And not because of the medicine, not because of science, and not because of lack of knowledge, but because of the just simply one thing, the fact where the child was born. And this is the world that we currently all live in. So next slide, please. Every year, every June, more specifically, near 50,000 of the world's top and world's famous oncology gather together in Chicago, USA, for the ASCO annual meeting. And we all truly love this meeting. The energy, the science, the breakthroughs, the plenary sessions in the city. But let me tell you something really honestly. You sit in a room where 10,000 colleagues, and we all hear about the recent clinical trials which extend the survival or and disease by 3 or 4 months, and it's truly celebrating thing, and it's rightfully is a breakthrough. However, outside of that same room, across the world, children are not losing months, they're losing their entire lives, and not quietly, not gently. They're dying in the pain, in suffering, in places where survival is the opposite to 85%, places where 85% of children with cancer die. And every year, more than 40,000 children are diagnosed with cancer. The majority, we all know, that live in low middle income countries. And we know for more than 30 years that with standard chemo, just chemotherapy alone, we can cure up to 85% of them. But the cure is not reaching them. And again, we are not talking about lack of the science. It's just because of the system. So what we can do about that? We can talk about this problem all over again. We write reports, we write strategies, we write declaration, but talking is not the same as saving the lives. And let me share a very concrete example from my home country, Armenia, which is a small, low middle income country, and where today the survival is around 75 up to 80%. And this is not happened by miracle. Just to remember, back in 1990s, the survival was reaching 0%. And now, this year, we have been able to increase the survival rate up to 80%. And it happened because of our teamwork, of our persistence. And I'm going to give you one of the success stories of that entire journey. Next slide, please. So around, just this is one of the examples, just around 10 years ago, we made a decision. There's a wonderful book, Early Diagnosis of Childhood Cancer, and this is supported by My Child Matters. We have translated this into Armenian, but we added one just small thing with our direct phone numbers and email addresses just in the translation of that book. And then we went to the regions, to the pediatricians, family doctors, rural clinics, and we gave them the books. And with the books, we told them, if you say anything suspicious, like anything, just simply call us anytime and any time of the day and time of the so and they have started to calling us. Within months, the cases of childhood cancer increased, but not because of the cancer increase itself, but because we finally stopped missing the cases. Early diagnosis is not technology. It is not artificial intelligence. It is not a new, like, novel biomarker, but it is a well-trained pediatrician. It's a book, a phone number, and a trust. And that is all from that side. On my next slide, I would say final slide. So on the last side, you see Dr. Julia Hovean. Several years ago, she presented Armenia's first national report on medulloblastoma treatment outcomes, and she leads now neuro-oncology in Armenia. And I say this without any hesitation, she has become a true expert in her field. For context, in the first 15 years, we had 75 children with brain tumors in Armenia. All the 75 in 15 years. Last year alone, we had 45 cases. What does this mean? Because we stopped losing these patients in the shadows. We created a multidisciplinary working group. As Professor Kebudi mentioned, multidisciplinary working is really important and essential for this. And Julia was leading this multidisciplinary working group, and it was a critical point. Julia was trained by the very best, our dear friend Ibrahim Kadumi, the legendary Eric Buffet, Simon Bailey, Nisrina Maria. She got the knowledge, she got the skills, and transformed the landscape of brain tumors care in our country. And now she's not only serving Armenia, she's contributed globally. And I will add, inequality in cancer is inequality in health is cancer, someone wise once said. I will add to this inequality in cancer is double cancer. So because when a cure exists, when survival can be 85%, when children die not just because of biology, but because of geography, that is a wound on all of us. And pediatricians are in the front line. Early diagnosis is in the front line, and you in the virtual room hold the power to change a child's life before they have met an oncologist. So if Armenia, a very small, limited resource constraint, can rise survival from 0 to 75 up to 80, imagine what we can do together globally. And children everywhere deserve the same chance to live, not a chance defined by their passports. Let us close this gap, let us act, and let us not allow another generation of children to be victims of an inequality we already know how to solve. And with this, I would like to thank you all.
Thank you so much. It's been wonderful listening to the representative of Dr. Tamamian, the CEOP Asia president, your excellent comparison of cities, and you're showing what a small country like Armenia can do, and in terms of survival rates, and then documentation, what it has done. You've shown trends in early diagnosis, survival, and inequalities across regions, and data-driven case for pediatrician-led early detection. Thank you so much for that excellent presentation. We now move, and our next speaker is going to be Liliana Pons from PAHO, and is going to highlight work that has been done. So over to you, Liliana. I'll tell you a little bit about her. Dr. Pons serves as Vice President of the Latin American Society of Pediatric Oncology and is a board member of the CEOP Young Investigators Committee. While also contributing to the PAHO Childhood Cancer Initiative, her work is directed towards strengthening pediatric oncology systems across Latin America, harmonizing treatment protocols, and reducing abandonment of therapy. She has led initiatives in acute leukemia management and supportive care, fostering sustainable regional collaborations that enhance diagnostic and therapeutic capabilities. So over to you, Dr. Liliana.
Thank you so much. Thank you to my colleagues as well for their nice presentations, and good morning from here as well. I'm really happy to join this wonderful session. Thanks to the International Pediatric Association, thanks to SIOP for inviting me to speak on behalf of the Pan American Health Organization. I will share my slides. I would like to bring maybe a couple of examples on why it's important that we're today speaking about childhood cancer. I would like to also thank all the participants and the pediatricians and all the colleagues that are joining today for this important topic. On behalf of PAHO, we're very happy to see how all the progress and all the activities, interventions that are done globally, and how this is really changing the prognosis and the future of many children. And also to hear the words from the survivor, from our colleagues, really motivates us all and make us feel that we are together in this common goal of increasing survival of children with cancer. In Latin America and the Caribbean, we have a strategic plan from PAHO to decrease the number of deaths and to increase the quality of life of these children. We know that 60 to 80% of the childhood cancer deaths are preventable, are the cost for the range of comorbidities and factors like you see here, from no diagnosis or misdiagnosis and no treatment, abandonment treatment, toxic deaths and relapse. And this was well noted by Nita, that we need to be focused on a call to action from every single part that we can do something. And I think the role of the pediatricians is very key, is the most important actually in the future of these children, how we can mobilize all the efforts to try to improve these factors that could prevent the death of a child. And we have our mandate on PAHO and WHO and all the partners to change this reality, to increase the survival rate towards 2030 up to 60% of children with cancer, to increase the survival of these children through framework, which is called the Cure All, based on pillars, based on enablers, but basically based on what we can do that could be translated from the strategy to the results. We have been talking and have been listening as well for many initiatives and strategies and different interventions that we could be addressing from where we are, but it is also important to monitor and evaluate how are we doing. So today I would like to address maybe some examples on how we can translate a public health activity into a result, into the impact that we can do for a child with cancer from the situational diagnosis, policies, projects and interventions, and health outcomes. So where we stand was the first thing that we did since 2021 in Latin America to understand the early detection gaps. And this is an example that I'm bringing today, how pediatricians can do more on the early diagnosis by knowing more how are we doing, right? We have interesting examples in the region, in South America, in Mexico, in Central America, that are very important to showcase that early detection indeed save lives, that this is one of the most cost-effective strategies that we can address in order to improve lives. So we gather more than 200 experts in the region to confirm different working groups. One of the working group was early detection. And we had this publication in 2023 to identify priorities in this area from the region, from a regional perspective, but with a local approach and implementation. So many of the key aspects that I would like to point out with these presentations are related to education and training, to how we can improve referral systems, how we can develop telemedicine tools and public policies indeed, and how we can translate this into the direct impact into children. So the first activity that was mostly addressed and focused on Latin America was education and training strategies. You will see here, since 2021, was developed a virtual course, and I also like to see the PAHO early detection manual that was the base of many of this material, but then was transformed into a more dynamic and practical with cases, studies that we can see in this course. So far, we have more than 188,000 trained participants, mostly from primary care, mostly from the medical environment, but also nurses, and other healthcare workers. So you will see that the reach of this type of tools is not only in the region, but we have participants from Africa, Asia, Europe, North America. Indeed, this is something interesting as well, because we have seen through these metrics and the monitoring and evaluation that I think it's the most important part of my talk, how we can measure this impact, is that there is indeed an increasing knowledge about childhood cancer. 23% increase in the knowledge for mainly primary care healthcare workers in 126 countries, and with a higher user satisfaction. Another key aspect is how we can communicate, how we can educate our community, how we can try to spread the word and increase awareness at different levels, because we all need awareness. Pediatricians need awareness as well, at least from where I come from. And I love the example that Regime showed from Peru. I will bring also an example from there, is that what we learn is that we need awareness from everywhere and to many different levels, from the primary care settings, but also from the referral hospitals, from our colleagues in other super specialties that need to know what is really happening in childhood cancer, being a major cause of death in children. So this is part of a strategy that was launched in February 2023, that has been currently adapted to 9 countries, has been translated into 4 languages and to 6 indigenous languages that we have in South America. Interesting, because the approach was not the same for the communities, for the native communities. And I would like to hear maybe other experiences in other parts of the world, but at least in the Latin American and Caribbean region, we have up to 13 to 15% of indigenous communities. And this is interesting as well, how we can address these materials. So different types of deliverables like jingles and videos that are aimed to be adapted and to be shared widely for the community. And one example that we had also was the work in sub-regional networks. So I'm a believer that if we share examples from different countries and we have this collaboration, what we call the South-South collaboration between countries that have the same goals, the same challenges, the same problems, then we could do a lot. So this is one interesting example from South America, in which a sub-regional network composed by 6 countries, that you will see the flags there, are working together to address the common challenges and to develop a strategy for early detection. So far, a big amount of professional has been trained. 5 out of 6 countries have already developed specific guidelines for childhood cancer on early detection. 4 out of 6 countries have developed communication campaigns. We have 5 publications for this project. So there's a lot of mobilizations, because we know that it's not easy to work with ministries of health. All of this work has been led by governments. And we know that childhood cancer might not be a priority for them, because they have so many problems and so high, and the highest political rotation and stability. But this is something that could be visibilized from every single corner to make change. Another example that I would like to bring that really fills me with pride is that during the recent years in the region, we have been able to work on early detection guidelines. That is the base for change. That is the base, because we know that governments change, and some of the teams also change, but we know that policies could stay, and could stay for being implemented by the teams. So the number of countries that with these national guidelines have tripled in recent years in Latin America, from 4 in 2016 to 12 now this year in 2025. And 2 interesting examples from Peru that was already pointed out, with the decreasement of time to diagnosis and the time to referral that has been led by the work of Ministry of Health. And in Panama, for example, with the decrease of the advanced stage of disease. But Quirola Americas and the work at the regional level is led by the hospital teams, by all the stakeholders that are working to this work. So far, 84 national projects and 26 regional projects are being addressed, 19 countries that are participating, and 11 that are in full implementation. And finally, just to highlight one material that we have published this year, and I think it's very important for all the pediatricians that get to know this, is a new version of the early diagnosis of childhood cancer manual. The previous one was from 2014, and this has been launched this year. But not only the format change, but also some of the content and the delivery of the information that we think should be very dynamic. In this manual, pediatrician can find algorithms for each of the categories of suspicion of childhood cancer. They can find photo galleries, they can find real cases, they can find algorithms by body systems, indicators. That is something that also in public health is very important for your hospital administrators to measure how you can be improving this, because success can be achievable. You have seen the example of some countries in my region, but this is happening everywhere. And this is happening probably in every setting that we can do something. Local guidelines that we need to follow to make an impact, and also communication and campaigns and more items you will find there. So I will leave you with that, and thank you so much for the invitation, and happy to discuss further.
Thank you so much, Dr. Liliana, for sharing highlights of work done, the regional initiatives on childhood cancer. Thank you for sharing with us primary care pathways and pediatrician-led improvements. Now, with these presentations, we have come to the end of this segment of the session. And my name is Ekaneme Kure, Professor of Pediatrics at University of Lagos. I'm the President of Pediatric Association of Nigeria, and I also serve as Coordinator, Pediatric Oncology Program Area Working Group of the International Pediatric Association. We're now going to quickly move on to another section, and I will introduce the person that is going to moderate that session. So we're going to have a panel discussion, and the moderator of that session is in the person of Dr. Akshant Jain. Dr. Jain serves as the director of the Inherited Bleeding Disorders and Hemoglobinopathies program, and is a faculty member in the Department of Pediatrics and Clinical Medicine, specializing in pediatric hematology oncology at the Loma Linda University School of Medicine and Children's Hospital, as well as the Loma Linda School of Public Health in California. So this session will be moderated by Dr. Jain. Over to you, Dr. Jain.
Hello, Dr. Cure, and this has been a great session, and especially hearing from colleagues from around the world, and the success stories and call to action, I think, are very apt for our audience, and certainly really heartening to hear the improvement in outcomes in parts of the world, which, even 10 years ago uh, was considered something that was uh, um, difficult to achieve or fathom. So not only, I think, collaborative work has brought global access, to novel therapies and better outcomes from early diagnosis and access to care, but also I think continued advocacy, part of which is something that we are doing here. I'm really happy to be able to moderate this session with this august panel of speakers. Um, Aishwarya, I think you had uploaded the slides. Yeah, great. So I will uh, probably put some of you on the spot in getting some questions addressed, but I think um, if anybody from the panel wishes to speak, um, I'll be very happy to invite solicit opinions as well. But I think my first question for Dr. Kibudi, I think is showing here, what are the most commonly misinterpreted symptoms that in your experience, certainly in your neck of the woods, but also from being present at global forums and having interface with physicians, not only from low middle income countries, but also from even countries with high resources. And how can pediatricians avoid some of these pitfalls? It'll be great if you could lead with maybe a couple of examples or clinical scenarios. I think it'll be very valuable for our audience here. Dr. Kiburi.
Thank you, Dr. Akshat. Well, I believe, especially for ALL, because the symptoms are so acute and really sometimes that cannot be missed. Usually, I think the diagnosis is made earlier, but for many solid tumors, there is a problem. As, for example, for brain tumors, when they have vomiting, usually it is a vomiting without nausea and with some pressure and so on. But we have seen many in my country and in many countries, because as I, Nita, and Liana, we are all in the international community with the pediatric hematologist oncologists, and we always talk about these problems. There is a lot of delays because when they have sometimes headaches also, headaches and vomiting, and they have been going to a lot of primary care physicians, pediatricians, and until the diagnosis, until they are thought, because sometimes they do not have very overt neurologic symptoms. If you have a hemiparesis or if you have a cranial nerve palsy, that is then the diagnosis is made very quickly. But otherwise, when it is only with headaches and vomiting, it sometimes takes months until they are diagnosed. So I think it is very important to teach all these early warning signs. And abdominal swelling, because many parents sometimes think that the child has eaten a lot and taken some weight, and they are happy because he has taken weight. Or however, usually I see that the mothers, when they are in young children, when they are in the bath, when they are cleaning the child, taking a bath, a shower, that is when they usually recognize that one part is more swollen than the other. But otherwise, they said, well, we had seen some swelling, but we didn't think it was something, a warning sign of cancer. For example, hematuria is I do love hematuria. In Wilms tumor, it's 1/4 of the children have that. But when there's hematuria, the parents will rush the same day. But with the abdominal swelling, with bone pain also, because and we know children run and fall down and they can have some pain in the extremity because of the bump that they had. But if the pain is in the same part and it's continuing, they have to go to a doctor, because we have seen such bone tumors, like the knee was the size of my head, and the child was being in the differential diagnosis, they thought it was arthritis after the Streptococcus beta, and was treated for penicillin for that. I mean, we have seen those cases, not in the last years, but because I have been in pediatric oncology for such a long time, I have witnessed this for example, 10 years ago. I mean, they were coming so late, really. First, because the diagnosis was being late, and then when they didn't have universal coverage until they had to do the imaging and so on, they were doing it late. But especially the education of the healthcare professionals. With the Turkish Pediatric Oncology Group, we did a program with the Ministry of Health, and we went to each city where the Ministry of Health, the healthcare professionals that were working publicly for the Ministry of Health were invited for 2 hours only. Because otherwise you cannot take them from their work. I mean, it was just after work, but not a long one, to teach them for early signs and symptoms of cancer. This can be done online also in every country. I think it is very important to teach both healthcare professions and pediatricians for early signs and cancer.
Absolutely. And I think it's a great response. And I think these examples that you've pointed out really hit home. Not very long ago, we encountered a patient with Hodgkin's lymphoma, or turned out to be Hodgkin's lymphoma in an adolescent, as you can probably all of you have experienced. Somebody with intractable itching that went on for months, and drenching night sweats, sometimes identifying these symptoms that are considered trivial or commonly ignored or misunderstood may lead to delay of diagnosis, and sometimes just common sense identification, maybe a chest x-ray or an early referral, can really shorten the lag time from symptoms to diagnosis and initiation of early therapy before we face issues of metastatic disease. So certainly very, very, I must compliment your examples, and to the primary care physicians, pediatricians, family doctors who are listening. I think all of the things that are presented today and have been presented by all these presenters, I think identifying early signs of pediatric cancer and adolescent cancer, whether it's solid or liquid malignancies, I think really makes all the difference for us to get these referrals in relatively quickly. Um, I think there is a question here in the chat box um, from Dr. Olufemi, which is I'll read the question out loud. Um, are there experiences with adult survivors of childhood malignancies? She shares her experience in her center in Nigeria. A lot of caregivers display a high degree of hopelessness about their wards with cancers. Dr. Ikure, if you wouldn't mind sharing some of your experiences, if that is okay, about access to survivorship programs and long-term care in childhood survivors. And then I'll open the question to the panel for your individual regions if you would want to share how survivorship is done for childhood malignancies. This is certainly a very timely and an apt question as we talk about improvement in cancer survival rates, specifically around liquid malignancies, with survival rates upwards of 60, 70, 80% in some parts of the world. We are now strategizing to create programs to provide access to care with specialty support for these survivors as they enter into late adolescence, adulthood. So, Dr. Kure, if you don't mind addressing that question, take it on from the panel.
Okay, thank you very much, Dr. Gurinde, who actually happens to be the immediate past president of Pediatric Association of Nigeria. So he handed over the leadership to me. Thanks for being in the room. And so the question about a lot of caregivers displaying a high degree of hopelessness again spans from one, our inability to document, for example, registries, following up, and actually having very reliable data of survivors into adulthood, because it is data like that that gives hope, and it gives the pediatrician the ability to create that hope in the patient by showing reality of what has happened. So yes, I agree that this is a challenge that we have, and luckily things are changing, and right from the government level, there is a lot of push for having these registries done across the country at the central level. And we do hope that with time, we will be able to put this data together, and that will enable the pediatricians to be empowered to give hope to these people when they come, to show that indeed the treatment can make a difference and that these children will survive. I hope that was helpful.
Absolutely. I see Dr. Radhakrishnan and Dr. Kibudi have their hands up, and I also see Dr. Radhakrishnan's comment. Um, uh, Ritu Bhalla, who was one of our speakers this afternoon or this evening, um, has dealt with this at a personal level. So I would invite her to share her response briefly, specifically around adult survivors in cancer malignancies and how it has shaped out to be in your region.
Thank you so much, Dr. Akshat. I mean, as far as we have dwelt with the survivor group and the community in India, we have seen a really sense of urgency and a level of anxiety when it comes to, either relapse or malignancy cases. Because again, as everybody highlighted, this is certainly a matter of fact of, lack of awareness. There is lack of information. There is lack of, social support services around patients that has, created these kind of scenarios. And until unless we have, these support groups on a larger scale, that will not be that will only be the support, the way to sort out this kind of scenarios and situations that I have personally seen and represented in our group, and in also talked about it in different multi-level stakeholder group, not only just on national but on international level as well. And to the first level of when it comes to dwelling with the problem, it is really important to understand the kind of challenges and barriers they are facing, and then systematically work on it, solving it one-on-one purpose with each and every stakeholder, identifying what are the immediate problem to sort out. And then it comes to uh, and there is a also, which we have observed, it's a factor of guilt which they take in their hearts when it comes to um, you know living in the society, or chasing their own dreams, or working out on their personal aspirations, career. But you know in back of their heads, every time, all the survivors who are facing this malignancy issue, or even if it is a basic cancer which can be cured, there is a sense of you know this is somewhere anxiety, problems. There are issue with dealing with day-to-day life, how to get back to the routine. These are very personalized challenges which we have seen, and we have guided them through as per our experience, and also learning from different stakeholders and experts like you, Dr. Nita, and other oncologists. And while we attend these kind of events, sessions, webinars, seminars, and workshops, we got to learn how to deal with these problems. So we collectively make an effort, and hence we help them.
Terrific. Thank you very much for your response. I see Dr. Radhakrishnan, your hand is still up. Was there a comment or a response?
Yeah, just a small comment on the earlier question actually regarding misdiagnosis. For us, I think one of the biggest wrong diagnosis is tuberculosis. So I'm easily 25 to 30% of our children who come to us would have been evaluated and treated for tuberculosis empirically without any evidence for it. So that's like an ongoing project with PSYOP, that we are looking at what is the impact of a wrong diagnosis of tuberculosis on childhood cancer outcomes. So that just adds to the long list that Professor Kebudi just mentioned. Thank you. And thank you, Ritu, for that bringing to light the ordeals that has to be faced by a survivor. When as a treater, we would just tell them that you just get the treatment done with, and 5 years, if everything goes well, everything will be normal. But everything is not actually normal. So there are a lot of work to be done, and kudos to all of you who have actually dedicated your lives for this community by becoming patient ambassadors. Thank you.
Excellent point, Dr. Radhakrishnan. And I think the overlapping symptoms of evening rise of temperature, having lip endopathy, chest X-ray findings can often be mistaken in for countries and regions where tropical diseases are still very prevalent, and just goes to say that the high index of suspicion for pediatric malignancies should never be taken off the table. I see Dr. Kiburi has her hand up as well. Dr. Kiburi, if you don't mind sharing your response, I'm sure
Thank you.
you would like to share.
Thank you to Rita for her experience, sharing her experience. And Nita, I think it is very important, Dr. Nita, that tuberculosis, especially in low and middle income countries, is really an important point. And also, we shall not forget that sometimes we see tuberculosis with the cancer together. We have publications from Turkey with lymphomas and tuberculosis together, and I had seen children come late and they were treated for tuberculosis, posterior mediastinum neuroblastoma, not only lymphomas, but even for that, and also for lymphomas as well. So I think this is a very important point that Dr. Nita has pointed out. For survivorship, I think this is very important. It is in high-income countries like there's in Syrup Europe, the PanCare group is working a lot, and in this children's oncology group, the survivorship panel and the guidance is very good. And what we did in Turkey, one of our colleagues in the Turkish Pediatric Oncology Group, Nurdan Taçyıldız, she's also the co-chair with Maya Prasad together from India and from Turkey. They are the co-chairs of the survivorship network in SIOP, in the International Society of Pediatric Oncology. She has taken the lead, and we have adapted the SIOP, the COG survivorship guidelines and adapted it to our resources in Turkey. As this is important, at least to take the lead, to be together, to do the education together. But still, although we, the pediatricians, like to follow our patients, even though they are adults now, we try to do that. But there are also problems because the medical oncologists have a high burden of patients, and they are not still too much educated in our survivorship in following our survivors. Usually we are doing it in person, trying to call them to say, like the cardiologist, now we have to do the cardiologic exam, and now there's the endocrinologic exam, or for the girls for the fertility, or for the boys for the fertility. I think it is very important because it is all, we know that chronic healthcare conditions are much more frequent in childhood survivors, and these really have to be addressed, and these have to be under the universal health coverage also. They are under the universal health coverage in our country, but still the organization is good within the pediatric community, but still we have a lot to go to have everyone together with the medical adult community. But it is important that we talk and work for it. Thank you so much. I think
Absolutely.
it's really
I couldn't agree more. And this was something that I was wanting to present it to all the panelists to kind of just share their insight. As we are having many of our especially for adolescent, post-pubescent girls and boys who are diagnosed with pediatric tumors, whether it's osteosarcoma, non-Hodgkin's or Hodgkin's lymphoma, etc. What is if there are any success stories and or access to barriers in fertility preservation, as that is something which is a game changer and certainly is a very important aspect in how that survivor is going to have a shot at a decent quality of life, having children of their own, and that gap to bridge from survivorship on to the journey on a relatively decent quality of life. At least I can certainly share our experiences in the United States. Not only conventional chemotherapy, but now having access to a multitude of modalities such as advanced CAR T cell therapy, BiTE immunotherapy, and or gene therapy, really preclude a lot of patients from being able to have a chance at fathering or mothering their own children. So we are taking more and more advantage, and very recently, at least in the United States, all recipients of gene therapy uh, are now eligible and covered to have free fertility preservation, egg preservation for girls, and sperm preservation for boys for a longitudinal period of 20 years, included as part of cost therapy that insurance covers it. So certainly that has been a big win for us here in the United States this year, for recipients of high dose chemotherapy, etc. But I'd love to hear it from the panel if there is any innovative indigenous strategies that are being used to address fertility preservation issues for these survivors. I'll probably start with Dr. Ponce. I know you have your hand up, and then we'll go down the line.
For the question, and I agree that this is such an important topic. Just looking at Ritu, for example, it makes me so happy as well to see her example and to see how definitely we need to address this. The experience that I bring from Latin America is that we don't have much data. Maybe that's the reality that we have in other regions as well. But we started to make a situational diagnosis as well for the reality of the childhood cancer survivors in the region. We published this year a paper that I could put the link in the chat. I put that in the answer as well of the question. But this is an important, I would say, a first snapshot on how the childhood cancer survivors are doing in the region. And just to give you some examples, including the fertility question, is that 60% of the participants, because it was a survey, a regional survey for 20 countries in the region, composed by participants from different countries, but mainly young childhood cancer survivors. 60% of these participants reported anxiety, depressions, or other mental health problem. And related to the fertility, nearly 1 out of 5 childhood cancer survivors had a problem or were experiences infertility. And many of them, according to this data, nearly 90% of the participants of the survey mentioned that they needed more guidance on late effects treatment. So this is an important problem. Of course, we need to do better on the survivorship care. In the region, there are very few clinics or survivorship clinics that are addressing this specifically for this type of patients, because we know that it's a journey between the completion of treatment and how are they going to engage to the society, what are the challenges it will be that they will have in school, in college, at the work opportunities, and many others. But there are interesting examples in Brazil, in Mexico, in Chile, I would say, that are interesting to see that they have made some progress, even though it's not at the level of high-income countries, but they're doing some type of surveillance and follow-up of these patients. Regarding fertility, it's very few that all the interventions that we have so far are part of these countries that have like a more robust programs for providing the opportunities to patients to have fertility preservation of fertility options. But I would just conclude that this type of models need to be more visibilized. This type of first of all, to know where we are again, because it's important to have the data. In our case, we're very much focused right now in these two aspects: in mental health and fertility, because these are the two big problems that we have seen into this situational analysis. And we have been able to develop with this consortium, because there's a Latin American consortium of professionals composed by professionals from PAHO, St. Jude, the Seattle's Hospital San Juan de Dios from Barcelona, and many other colleagues that are working together for providing data and also developing materials. So far, we have been able to put some infographics, and we plan to have these educational materials also for pediatricians and for the physicians that are adults, physicians that are treating this type of patients. Thank you.
Great. Thank you very much for sharing. Aishwarya, if you don't mind, moving on to our next question. We're running a little short on time. I want to make sure we have all our questions for the panelists addressed.
Yes, I'll just share the question. Give me a second.
I'll address this question, maybe Dr. Radhakrishnan. What are the minimum follow-up elements that any pediatrician, even outside a cancer center or maybe in a hub and spoke model, even if they're working in a spoke, should monitor in all childhood cancer survivor? We did touch upon many aspects, specifically mental health and fertility, but what would you recommend as maybe the top two follow-up items for any pediatrician when they're seeing somebody with a history of childhood cancer diagnosis in the past?
Yeah, thank you for that question. So yes, as soon as actually the care of the pediatrician does not start after completion of treatment. It is during the treatment that we start a link with the pediatrician, a primary care pediatrician, so that shared care can be initiated. Like it was discussed in the beginning, like febrile neutropenia, we should not be missing out on the golden hour or antibiotic timings, etc. During the treatment. And as soon as they finish treatment, we provide a summary for the primary care pediatrician. So sometimes families move to the nearer to a cancer center for treatment, and after that they go back to their villages or their towns. And then you need to be, we may not know whom we are referring to. So there is a proper referral summary that is given. And we encourage them to watch out for symptoms of relapse, definitely. So other than the regular visits which are scheduled, they will also be advised to go to a primary care pediatrician frequently. Now, after this, after the initial few months go away and then they're all fine, then we start the focus will be on nutrition, vaccination, and growth and development. So these are points that we keep in mind and we ask them to follow up carefully. And finally, we also want some kind of social reintegration. So that reintegration bit into the community, going back to their school, going back to a good, the way they were previously, pre-morbidly, how were they socially? So they should go back to the same situation. So these are things that we would highlight. And any issue that the pediatrician faces, there will be it was ideal that we have a good linkage and we have some kind of a real-time solution to be provided. So it cannot be like many of the answers many of the questions would require answers in real time. We cannot wait for weeks together to get to them. So we kind of find networks in place so that they have answers quickly and the pediatricians are more empowered. So another thing is, initially there may be primary care pediatricians who are a little bit apprehensive to manage children with cancer, but once they have managed a few of them, then they kind of understand the whole process and it becomes much easier from then on. So it's engaging them during cancer treatment would be really helpful. Thank you.
Absolutely. Couldn't agree more. I think we can move on to our next question, Aishwarya, if you don't mind sharing your slides. And again, keeping 5 minutes remaining in our session, I'd like to address this very important question about referral systems and shared care. How can pediatricians be trained or supported to handle complications such as febrile neutropenia? I think Dr. Radhakrishnan mentioned about the golden hour, access door to antibiotic time, etc. All of that encompassing in febrile neutropenia management in settings without specialized oncology support. Dr. Kibudi, if you don't mind
Yeah, thank you.
responding to this
Thank you. This is
question.
an important question. We have been put this into the medical faculty curriculum. So when we are teaching medical students, we have some lessons for teaching early diagnosis and early emergency measures in pediatric hematology oncology. Pediatric febrile neutropenia transfusions is one of them, because it is, and also, as I said, when we went to these with the Ministry of Health and the Turkish Pediatric Oncology Group to pediatricians and healthcare professionals, not only pediatricians, we also taught not only for early diagnosis, also for these kind of pediatric febrile neutropenia, emergency transfusions that are needed, because this saves lives. I mean, you can really save the life of a child, because they can die of a complication and not of cancer, because if you cannot treat them early. So I think it's the education should start from the beginning, but also in the pediatric associations. All of them have some congresses. In the congresses, it may be short, but all the time having a session on early diagnosis and also a session on how to do emergency, how to solve the challenges of emergency situations in pediatric hematology oncology is the best, I think, at the moment to reach them. Of course, these online sessions of the IPA are very important, because IPA has a big power, so many countries, so many national societies. I think these kind of online sessions also will reach them internationally.
Absolutely. Great. Thank you, Dr. Woody. Very timely and rightfully mentioned. In addition to febrile neutropenia, also management of hematological matrices, especially when they are critically low. Next question, Aishwarya, if you don't mind. In your country, is there a formal referral network between primary care pediatrician and the tertiary care centers? There are always regional differences, urban versus semi-urban centers. But Dr. Ikure, if you don't mind taking up that question about referral network in your region, specifically around connection between referral centers.
Nita, are you taking the question? Otherwise, I can shortly say, oh, sorry, Dr. Ikure, yeah.
Okay, thank you very much.
Did you get the question, Dr. Ikure, or do you want us to share it again?
Yeah, I saw it's about referral system.
Yes.
Right.
So connection between a tertiary care center or a referral center to the primary oncology center. How has that been practiced in your region?
Interestingly, in our country, most of the oncology centers for children are located in tertiary institutions. There are few standalone oncology centers, for children. So that actually makes it easy, because the centers treating the oncology are, within the tertiary institutions themselves. So the problem is more of a referral from the lower systems, like the secondary system, to the tertiary institutions where the oncology centers are located. That's where we have bigger challenges. In the private sector, we're also beginning to have private oncology centers where patients could go directly, but there are a lot more public centers that are in the tertiary institutions that are in the public sector. So in relation to that question, it's not a big problem for us, because they're all in the same space. Thank you.
Great. Looking forward to interfacing a little bit more with you, Dr. Ikure, offline we are bringing our medical school that we're running in South Nigeria, the Bakbak University School of Medicine, and we're having some, again, regional issues and challenges with referral networks. So certainly will interface with you, and as is true with any resource limited setting. I think we have maybe time for one
Great.
last question. Aishwarya, if you don't mind sharing maybe one last question for the panelists. And this question will be for Dr. Pons, Dr. Liliana Pons, if you don't mind. What would you suggest the pediatrician, guidance to pediatrician to handle situations when a family declines or delays referral to a cancer center? A common issue, sometimes mired in socio-cultural beliefs, sometimes mistrust or distrust in the healthcare enterprise. It's a broad question, but I would request you to try to briefly answer this question, if you may.
Thank you so much. And I will try to briefly comment. This is a huge problem. As we know, abandonment of children remains to be the major cause of treatment failure and refusal. Upfront refusal is so important in many types of diseases, retinoblastoma. I've seen bone tumors, sarcoma, of course, as well. So I would advise that we first start with empathy. I think it's very important to acknowledge the fear that the family is facing at this moment, the confusions, the mistrust that they could be so overwhelming for them, and then to always talk with transparency with family. I think it's something that it's important to address because it could have legal implications. It could have, of course, medical implications as well, because this will affect the prognosis of children very importantly. But to identify some specific barriers is also important because major causes for this type of situation would be psychological, would be also socioeconomical from the families. And what I've seen as well is that in many cases, the family does not have the trust sometimes with the physicians. They would like to talk to someone else, to the nurses, to the psychologists, to other professionals. So to work as a team for helping the patient, that is the most important, and to have this shared decision making and a recommendation for the family. I think that would be my suggestion, and also to keep looking on how we can educate more patients and how we can have more empathy for them in order to have more to have better outcomes. That would be my advice.
Absolutely, couldn't agree more. I think that brings our panel session discussion to a close. I'll pass the baton back to Dr. Ikure if there are any outstanding questions. I couldn't see any in the chat. Thank you, everybody, for such a lively discussion. It was very insightful. Appreciate.
Thank you so much, Dr. Jane, for moderating this panel discussion. I also appreciate all the panelists. We're going to have a closing remark from Professor Nita. So, Professor Nita, over to you.
Thank you. So that's been 2 hours. And I think as we conclude today's session, we have seen quite a few clear themes that have emerged. We've seen that there is evidence that early recognition and timely referral that was focused by all the speakers today. And especially in resource constraint setting, it is very important. It is a decisive determinant of survival in childhood cancer. The passport should not matter, like what Dr. Rosanna Papayan had mentioned. So I'm thankful to all the speakers who have joined in today. Thankful to Ritu Bhalla, who reminded us that there is a lived reality behind all these numbers and all these diagnoses that we see, that it takes a lot of courage, a lot of resilience to be there and work for the community. And having gone through a lot of challenges, and timely referral becomes very important. Coordinated care, even after completion of treatment, that is very important. I would like to thank Professor Regin Kebudi, the Secretary General of SIOP, who has showcased her personal experience in Istanbul and Turkey on how to bring pediatrician associations together for improving pediatric cancer outcomes, and also showcased early detection practical tools that can support pediatricians in real-world setting. I would like to thank Dr. Ruzana Papian, who joined and presented the global epidemiological data demonstrating survival gap that early recognition can shift. Huge thanks to Dr. Liliana Ponce for highlighting impactful models such as PAHO, which can be adopted without much difficulties in most of the other regions of the world, and how showing that this kind of systemic level of collaboration between organizations, between the state and the governance can actually help reduce disparities. A huge shout out to our moderator, Professor Akshat Jain, for focusing on actionable strategies which can be used for early diagnosis, shared care, survivorship, advocacy, etc. And the experiences today have really underscored that if we work together, if we strengthen systems in the regions that we work, it is possible that even when resources are limited, if we bring the stakeholders together, especially the pediatricians, the pediatric oncologists, the public health framework, it can actually create importance. So the takeaways from my side are early suspicion saves lives. So we discussed the early warning signs, it was shown, and all the how mistakes can be done, that was also highlighted in the panel discussion. Another key takeaway is that structured referral pathway is important. We also discussed that survivorship and psychosocial support must be integral. It's not an option at all. It has to be integrated into the system. And advocacy by pediatrician is essential for a systematic change. And finally, I would like to thank Professor Ikana Mekure for again dedicating time and taking leadership as the chair of a pediatric organization in Nigeria to bring this work forward, bring this important webinar to fulfillment. I would like to thank Professor Joseph Haddad for his leadership of IPA and how by bringing focus to this area and translating today's insights into concretable action. So whenever there is there's an opportunity to showcase from IPA side as well as from PSYOP side, there has been action both in WHO as well as UNICEF. Wherever there is an opportunity, they've been working, and that is how leadership really impacts the outcome. So thank you to PSYOP leadership for again taking the cause of childhood cancer ahead, and such joint sessions between IPA, PSYOP, and all the stakeholders are definitely the way forward to improving care and to make sure that no child anywhere gets left behind. And finally, thanks to all the participants, the IPA administrative team, for your engagement and dedication. I would thank you again. And I think that's it, Professor Akure.
Thank you very much, Professor Nita. So that brings us to the end of this webinar. Once again, thank you very much for joining us. Bye.
Thank you.
Thank you.